confirmed COVID-19 cases and the number of deaths, which has surpassed 1 million globally. And it has been a big shock in the entire healthcare world, basically. And what we noticed was that children have a relatively small role in the spread of the virus. And there's been large studies here, done here in the Netherlands and elsewhere around the world, where we see that the number of children infections, child infections, and children infection spreading to adults is very small compared to the infection spread between adults. So the children themselves have a relatively small role in this virus, in this pandemic. However, we noticed that in the Netherlands there were very rapid and severe limitations in treatment possibilities for pediatric rehabilitation patients. So even though that the children had a small role in the spread of the virus, there was a big effect on the treatment we could give these kids. Just to give you some context about how the COVID-19 pandemic spread out at first in the Netherlands. February 27th of this year, we had the first confirmed patient. And after about 2 weeks on March 9th, the first restrictions were in order, where our government told us to stop shake hands. And I believe to stop events with more than 1,000 people involved or something like that. But quickly afterwards, the pandemic worsened. And 2 days later, social distancing measures were enforced. People were obliged to work from home. And about 5 days later, on March 16th, at least in Amsterdam UMC, where I worked, we had to stop almost all outpatient care except for the very, very urgent care, and stop a lot of regular clinical care to create capacity from healthcare workers for COVID-19 related care, where both doctors, nurses, physiotherapists, and others had to work in the clinics just to take care of the people who were brought in the emergency room and had to be admitted. And after that, for about 2 months, we've had very little patients in the outpatient clinic. And only after 2 months, we slowly started to increase the care we were able to provide, starting off with about 25% of the usual contacts, and then increasing that percentage by time, where recently we got to basically 100% of the care we were giving before the first COVID outbreak. And right now we're entering a second wave where some hospitals have started to reduce the amount of care they could give regular outpatient care again. But in this first period, when we saw very little patients, and we only had we only called them frequently, we decided to put our time to good use, and set up a study to gain more insight in what effects these COVID-19 related restrictions in healthcare in our country had on pediatric rehabilitation. We wanted to see how therapists and physicians dealt with those restrictions, and whether there were creative workarounds. And we were interested in what the biggest worries were, because we had some ourselves, but we were very interested to hear from everyone involved in pediatric rehabilitation in our country what their biggest fears and worries were regarding the patients they usually see, and the families, of course, involved. So what we did was we contacted all the members of the Dutch Academy of Childhood Disability on April 7th. And we asked them to participate in the digital questionnaire, consisting of 19 mostly open-ended questions. And people were also allowed to send the questionnaire to others who it might concern, other caregivers and healthcare workers in childhood disability and pediatric rehabilitation. the questions we asked them were a result from a group discussion between all three authors of the study, where we asked basically 5 questions to gain more insight. And the first regarded like the institutional restrictions there were, whether these were similar all over the country or whether there were large differences. We wanted to hear what effects these restrictions had, how institutions still tried to deliver the best care they could, how the knowledge regarding COVID-19 related care and pediatric rehabilitation was provided to healthcare professionals and also to patients and their families. And we asked them about the biggest worries regarding patients and their families due to a lack of what we usually would give in care from our point of view. And it's good to know that in this case, institutions could mean hospitals, could mean primary care facilities where people with childhood disability were treated, could be specialized daycare, specialized schools, all sort of institutions, just to get a broad overview of what was happening in the lives of these children and in the care they were receiving. And because it was such a variety in the data we got, we soon realized that this study was more appropriate to look at from a qualitative point of view, rather than counting and checking. So we did a qualitative description study, which is meant to look at data in a structural way, by using coding. So all items that were answered by the healthcare professionals were looked at and were coded specifically for what it was that people said. And then in team discussions, we did actual and then inductive coding, and out of that came 3 large themes that emerged from the data. And on that, we did a thematic analysis. Yes, as I said, we often discussed what we found, how we could interpret that, what was clear, what was unclear, and go from there. And we did a qualitative description study because that enabled us to look at a large amount of data in a short time. Because we found that the results that we had and the data that we had, we needed to analyze it quickly because it could be of importance for the near future, rather than doing a very deep grounded theory kind of study, which might have given us an even better understanding of the processes that were in play, but which takes way more time. And the results might have come in too late to still be irrelevant. In the end, 237 people participated in our study, various institutions and various occupational backgrounds. So we had rehabilitation physicians, we had physiotherapists, we had speech therapists, occupational therapists, and all kind of other healthcare workers involved in pediatric rehabilitation and helping patients with childhood disability. And out of our analysis, 3 major themes emerged, which I would like to discuss with you in detail. And the first theme that was a big issue were the treatment possibilities there were. And what we noticed from the answers were most institutions had very clear restrictions in what patients could be seen, could not be seen, and what care could be provided. However, there was a large variety in how institutions implemented these restrictions and between the institutions. And that meant that one institution said, well, that, for instance, chronic pain rehabilitation in children could still continue because they deemed it as urgent care, where others postponed basically all care they provided. And so there was a large variety in what was done and what could be done, what could not be done. And that resulted in, for instance, patient that needed plaster casting after botulinum toxin treatment could sometimes not be seen in hospital. And then when they were at home, their physiotherapist told them that in a rehabilitation center, this care was still possible. And that led to referrals to other centers and a lot of uncertainty for patients and their parents. What was always continued was clinical care, of course, and care after botulinum toxin treatment was usually continued, but not always, and often in downgraded, where the number of actual contacts was reduced as much as possible. And post-surgical care for patients who underwent, for instance, multi-level surgery, that was almost always continued, because we know that if you would stop that care, then the surgery might have been for nothing and could have effects for the rest of their lives. So that was almost always continued. The other outpatient treatment possibilities varied greatly. As already said, some chronic pain clinics kept on seeing patients, where others and daycare centers were completely shut down. And looking at how that was possible, it turned out that almost all institutions had in their restrictions that only urgent care could be continued. But what urgent care was almost never clearly defined, and so there was a large variety in how that was interpreted, and those measures were enforced. What was good to see that some institutions had very specific plans worked out, whereas they had in detail they discussed within the team these kind of patients, or with these diagnoses we will keep on seeing, and these kind of problems or diagnoses we won't see. And other institutions such as daycares often had an order in which they would see their patients if they could see any patients. So they would say patient A is the most urgent. As soon as we can see or have any patient in daycare, it will first be that patient, then that patient, then that patient. Ranked by how important it was deemed by the team. But many other institutions also had no very specific plan whatsoever. And what we heard was that there was a lot of implementation of e-health and telehealth, a lot of video conferencing, and some institutions still had problems with the ICT possibilities to actually give this sort of care. But what we saw was that was implemented very quickly, and basically everybody was very flexible to still be able to see their patients the way they could without within the restrictions that were implemented. The second theme we found were the worries, which was a very important one. Because the biggest worries of many of the therapists and physicians was that the children who require most care are often the most difficult to treat using some form of e-health or telehealth. Especially, for instance, patients with fast progressive neuromuscular disorders, the patients with cerebral palsy, GMFCS 4 or 5, patients and families with a language barrier. That was often the worry, that these patients who required most supervision and most intensive care from our point of view were the ones who was most difficult to achieve that with. Second, besides these things, also age and instructability were very important. Especially small children, it's difficult to have parents treat their patients and instruct them what to do. And also, if children could be instructed to do certain exercises or training, then that was often possible through video. But if patients were of a lower cognitive level or otherwise not able to be instructed well, this was a big problem. And the last thing we found was the high burden there was on families and caregivers. In the COVID-19 pandemic in the Netherlands, parents were not only parents anymore, but they were also expected to homeschool children, both our patients, but also healthy siblings. Besides homeschooling and being a parent, they were still thought to be working from home, and they were also instructed to do therapies like physiotherapy, and all in all, this gave a high burden on families, and many parents explained that this was too much for them. They couldn't do this. But also to end on a more positive note, what really stood out was the opportunities that were created and have arisen from this COVID-19 pandemic period. First of all, the telerehabilitation, which was definitely on the rise. Before the COVID-19 pandemic, almost nothing was done through telerehabilitation, almost nowhere in the Netherlands. There were a few video consults, a few telephone consults, but that was it. And now, we've seen what the possibilities are. Giving hints or exercises, instructions, training schedules, homework assignments. It was found by many therapists that it was feasible to do this through telephone or video. And one of the nice things of that was that parents were also able to make videos of their children doing certain exercises and activities. And sent these back to therapists, which then the therapist could see, like in real life, in the real setting of home, what happened with their patients when they did certain activities, and they were able to give feedback on that. Besides that, we noticed that there was a big community feeling between all the therapists, which resulted in communities in social media, for instance, where a YouTube channel was started by some of the physiotherapists. A Facebook group was started by, I think, the speech therapists. There was a Pinterest page of all kind of activities that could be done at home by occupational therapists. Homework assignments were given. And one of the very nice things I thought was that a group of physiotherapists also started garden consultations, where they didn't actually see patients at their home, but they went to their garden and then they did a treatment session in the garden of the patient. Of course, what arose was that many institutions had lack of ICT support or suboptimal ICT support. Which is essential if you want to provide this kind of care and you want to do a lot of things through video or telephone. You need to have the equipment to do that. What discussions did this raise with us, and what is probably also worth discussing with you is there was a large variation in how the institutions implemented the restrictions. And is this desirable, and or how could you manage this else in another way? Also, because, well, the usual care was back to normal for now, but again, the restrictions are starting to rise again. So it's important for us to know what patients we can see, what treatments we can give and what not. And I think it's important to also discuss this with other institutions, because in my eyes, it would be very important. It would be important to have similar ways of doing that. how usual care was started again also varied greatly, which meant that in some instances, doctors were allowed for themselves to determine which patients to see first. In other institutions, it was on a chronological basis. All the appointments that should have been physical ones but were cancelled were then chronologically planned again. And there was also a large variety in the care which was given. What we realized was that the family situation was delicate. There was a high burden for many families, and there was little attention for that, which is something that should be improved in our opinion. And that the most vulnerable group of children will need more attention, especially in the times that after severe restrictions. I feel that it's important to first see the most vulnerable group of children and to identify these because they are the ones who will experience the most negative effects if restrictions have to be enforced again due to a new outbreak in the COVID-19 pandemic. And what we saw was that there's many opportunities for research. There's been debates in the Netherlands about what the effect of therapy, of giving a therapy has on children, but it was deemed not ethical yet to test that because we feel that giving therapy is better than not giving any therapy. But now we have had a period with very little therapy. So this, because of other influences. So this has given now the opportunity to study what the effect was. The study itself had some limitations, obviously. We have only focused on therapists and physicians, not patients and their families. There was another study performed by one of the patient federations, who's also done a quite similar thing. And what is unclear is the effect on functional outcomes. So whether our patients are actually worse off, we don't know. We do think they are, but we can't say for sure. And what was interesting to see was that we had quite little response from healthcare workers from hospital settings, and most responders worked in either rehabilitation centers or in a known practice or in daycare or in school. So what we feel that we can take from this is what urgent care entails. That was unclear. There was lack of agreement on, and that might be important to get more of a concrete idea about that. We fear that the most vulnerable children have suffered most, and that the new treatment possibilities that were created are worth investing more time and energy in to perfect their usage. Because we think it's it opened up a whole lot new opportunities, which we should continue in the future. I would like to thank Professor Buizer, Dr. Alsem, and the Dutch Academy of Childhood Disability for their support in this study, and all responders to the questionnaire, and of course to all of you for listening to the presentation. And so, I've posed a few points to debate about, and it was very interesting to hear how others have experienced this period, how you feel the care has been, what restrictions have been given in your country, how those were enforced, how the starting up of care was regulated, and any other things we can learn from other countries over the globe.
Jorgis, thank you very much. Would you please be as kind as to stop sharing your screen so we can see all of the participants in this session? Those of you who haven't turned on their camera yet, would you please turn on your camera so that we know who you are? Hello, everyone. Hey, there they are. Great. Any comments? Could you please raise your hand if you want to make a comment? Marianne, can I give you the first floor?
Yes, thank you for your very nice lecture, Joris. I would like to ask if you have any data. You tell us that there's a lot of difference in the Netherlands, but during the first COVID crisis, we also had a big difference where the crisis was severe and where less severe. For example, in the north of the Netherlands, there were actually no problems, and down in the south where I lived, there were a lot of problems. So I can imagine that when you are living in the north of Holland, the rules for were not as strict as they were in some other parts. Do you have any data on that?
Unfortunately, no, because the respondents were allowed to respond anonymously, and for that reason, we know what kind of institutions they were affiliated with, but not their actual institution. So yeah, I don't have a clear answer on that.
Okay, that's very clear. Thank you.
Yeah, it could very well explain why we found large differences in how.
I think it doesn't explain all, but it could explain some of the differences.
Yeah, I agree.
Okay, thank you, Marianne. Any other comments or questions? This was a very clear presentation, yours. Thank you. All right, what are your experiences then over the last period? I mean, if we're talking about regular care and acute care, what would be the difference? How can we envisage care that is most needed? How do you go about that? Anyone? Dawn, Susie, Shiri, Badit?
I think one of the challenges around that is also it changes, doesn't it? Because at the beginning, it was very easy for us to say, you know, priority not to treat people because of the pandemic. And then as time goes on, you know, who is that most needed person sort of changes. The balance of risk changes as we're sort of looking at someone perhaps that's not had intervention for months, as opposed to someone that's missed a couple of weeks of something. So I think it's difficult because it's a constantly changing picture, and what seemed like a reasonable risk assessment on week 1 is a different risk assessment on week 12.
Joris, can you comment on that?
Yeah, I agree. I think that at first when we stopped to see patients in person, we had no idea what was coming. And so what we were doing in retrospect, you might have thought, well, we could have taken care of that differently. But because at first you don't know what's coming, you don't know how long the period of restrictions is going to be. So it's very difficult to anticipate that beforehand. And yeah, what we saw was that for many patients, we said, well, this is not urgent care. We don't need to see them right now. But that changes over time, and especially with young children with spasticity or cerebral palsy, it doesn't matter if you see them 1 month later or maybe 2, but after 3 months you're going to want to see them because the risk of contractures is getting too big. So yeah, that definitely changes over time. And it makes it very difficult because it's not only the disease the children have and the social support they have and the network they have, but also their age, whether parents, you can trust parents to warn you timely if something's going the wrong way. So that makes it very difficult to just say these children have highest priority and these have lower priority. It's not just a tick box exercise, but it's really personalized care that needs to be given.
Dawn, you wanted to make a comment?
Yeah, thanks. So I was just for interest, really, just how in your region, what's the sort of the regularity of the therapy sessions? Like, how often would you in a normal situation? How would you typically see them? How often?
You mean in the hospital as a pediatric rehabilitation physician?
Yeah.
Yeah, depends on the patient, their age, and the severity of the disease. But I would say like very young children would be once every 3 months, up and about, and up to once a year for children for whom most care is organized and are relatively stable in their functioning and disease.
Okay, and so that sort of timing has changed considerably then, obviously.
Yeah.
Since okay.
Yeah.
And then
so,
sorry, go on.
Most of the regular checkups, the patients who we would see after 3 months, we decided that we really had to see them within 6 months. For the patients who we see every year, that could be prolonged to like 18 months or something. And yeah, the past period where there was a low amount of new infections enabled us to get back up to track as well as possible.
And you said that you'd got back to sort of usual care, although it was varied. What was that? Was that usual care back to face, or are you still doing your risk assessments? And
I think we've done quite a lot of things back face to face, but not all. Well, we got usual care back to normal, but we did still have a backlog. So we saw the same amount of patients in the end, in general, in the Netherlands that we were able to see before. But we had a backlog, and I don't think that's all.
So back in the clinic, so not using telehealth.
Yeah, many patients are still seen in the clinics again. Yeah.
Okay.
I have to say I switched hospitals in between, so I'm not sure how it's in the hospital where I was situated before, but maybe Dr. Booker can tell us.
Yeah,
I was already waving at you, Joris. Go ahead, Evelyn.
Sorry, yeah. Yours, was it my hospital? It's not completely back to normal yet. We see littler patients than before we saw in the outpatients clinic, and we still use a lot of phone calls, mostly to check up how urgent the face-to-face contact should be. So it's still different. It's not the same as like a year ago.
But that again varies per institution, because in the hospital where I work now, I think they see exactly the same amount of patients as they did before.
How is that for other people? Are you back to normal, or are you still working on a backlog, or how do you go about that? Anyone? Shiri?
Yes. Hi. First of all, thank you. It was very interesting. I'm from the north of Israel, working in a daycare center. For the first lockout, we were closed, and we were connecting with the family and treat by phone, by videos, by YouTube channel, by Zoom, all kinds of ways. But now we are open normally and give a treatment like we used to, with mask and everything, for the hygiene. But we treat normally, because we saw in Israel they see that when we stopped the treatment, it was the children came back with contractures, with the ASD children came back very different, and so we cannot be stopped now. I would like to ask, you mentioned something about Facebook group, and we thought about it, and I would like to know what was the purpose, and if it was only for therapists or therapists and parents, if you know, because we thought about the parents that maybe they don't want to connect with other parents emotionally, maybe. And on the other hand, there's also the confidentiality medical, so we cannot expose them to with the diagnosed and everything that the child has.
Yeah. What was done was the Facebook group was only for and by physiotherapists, speech therapists, because they exchanged information about what kind of treatments they could give and how that worked out through video sessions. So that was only for the practitioners. Whereas there was a YouTube channel by some pediatric physiotherapists where they did all kind of training and exercises and that sort of stuff. And so on that, parents could also respond, and so that was more of an open also for patients. But I'm not aware of. At least it was in the data that was in the study, but we studied patients only, we studied this during the first 2 months of lockdown, so it might be that afterwards, other initiatives have started. But during the time of our study, there was no specific mention of communities of parents, support groups or something.
Okay. Thank you.
But maybe anyone knows whether that has been whether such initiatives have been developed.
Anyone?
Hi, this is Naomi from Al-Ain Hospital in Israel as well. We've been doing parent groups with children from our daycare centers and also from the rehabilitation departments. We did this specifically a group of mothers of children that had pertus. So it was diagnosis based, together with the parents themselves, an orthopedic surgeon, and a physical therapist. And we've been doing groups, language-based groups, Hebrew and Arabic, with parents, mainly mothers, but not only, excuse me, during this whole COVID time, together with social workers or with psychologists. So it is something that the parents do want. And we've been trying to be very flexible in the times that we do it. So we're trying to do it later in the day so that both parents can join.
Brilliant. What we heard from psychologists here is that if they work with parents and it's starting to get emotional, then they don't know how to react. Is that something you recognize?
Yeah, my psychologist from Al-Ain Hospital spoke this morning and said exactly the same thing. And it was something that they talked about just before they started therapy, about what would happen if that happens in a session. So yes, definitely, it's something that that is on the table.
And what came out of that discussion? Any hints?
It was easier when it wasn't. This is something that I know that wasn't brought up in this discussion, but it was easier when it was parents that first had face-to-face time with the therapist, and then only afterwards there was parent consultation. So there was already a rapport between the therapist and the parents, and even when they did start only to do through via Zoom, they did try to at least bring in one parent to do a little bit of hybrid sessions, so that there would be a connection.
Does any one of you have experiences with doing telehealth consultation with children who say, "Oh, this is interesting, I have to show that to my mom," and then be off, and then you see an empty screen? Any one of you, or nobody? No? Good. Okay, yeah, sorry, Rina.
I want to say all the time, or a lot of the time. And that's part of the fun of it, you know. Children also want to show off. They take us through, especially if you know the child, you've had previous contact. I find they want to show their home and they want to show their toys and stuff like that. And I just use it positively and, you know, have a conversation around that, or then try to do what you want to do where the child moves to, you know, the place they move towards, if that's possible.
Great.
Yeah, I think that's a very important aspect of the video consultations and why they work better than just phone consultations. Because what I hear a lot of patients and other healthcare professionals is that it does really make it easier to connect and also to form an emotional bond, and it makes it for children more fun. So they can show their room or whatever. Yeah.
But on the other hand, for the very young children and more mentally affected children, telerehabilitation is very difficult.
Yeah.
And how can we improve that then, Marianne?
Well, we didn't get any solution for that. On the other hand, in our rehabilitation center, we found it very difficult to do tele-rehabilitation for the young children, and our neighbor rehabilitation center managed quite well. So there is, I think there is also in our rehabilitation center lack for improvement, but the multiple handicapped children, we don't have a real solution, and that I think that's one of the group who's most vulnerable, and I think it's still a big problem. And what I also experienced, because George, you talked about cerebral palsy and contractures and things like that. Well, I'm mainly a doctor of the very young children, the early treatment. And what I experienced now, that especially the children who were not at high risk, but that the process of the parents actually rather stopped, because they when a child with a developmental delay comes to the rehabilitation center in the daycare groups, it does something with the parents, because they have to admit there's really something wrong. And now the child was at home again, and it was, of course, it was improving a little bit. So, and now it's 3.5 years, and in a half year it has to go to school, but they are not. The process of accepting that the child needs something special has actually stopped. Not with all of them, but especially, of course, always, especially with the ones who were denying the problems the most. So I think there's a lot of, not only that we have a lot of patients we want to see now, but now we see that even the non-urgent children, they have big problems because of the delay in treatment.
What about fathers then?
Yes.
I mean, we hear a lot of stories that fathers suddenly realize, oh my gosh, care for my children is wider and broader and more intensive than I usually thought it would be. Any experiences of that?
Well, in our data, we also found that some families were actually, some families had told therapists that they were actually more involved in the therapy of their child, because they didn't just bring them to a daycare center, didn't see them all day and pick them up again, but rather they had to be really genuinely involved in therapy. And for some parents that worked really well. And I can see that these parents might, it might be good for their acceptance, but rather, some parents, for them it was too much of a burden and they couldn't handle it. And I can also imagine that if you don't, go along with that therapy, then they could, it could stop the process of accepting that there is a problem. And
I do agree with you, Joris, because sometimes we heard that there was more. Rust. I don't know the English word at this moment. And they saw what a child could do at home. And they also saw sometimes the problems more, and sometimes they experienced not having to rush all day was very beneficial for the whole family. And a lot of parents also told me, now I see the learning problems, because they had to do some school works at home, and now they saw how difficult it was. So it has both sides of it, but it's very difficult to predict what side for this will prevail.
Yeah, I agree.
Who of you felt frustrated that he or she could not deliver the usual care or the care they actually wanted? And how did you go about it? How did you deal with that? How did you cope? Anyone?
I think you've just got to be flexible and make the most of it. And I've seen quite a few presentations over today and saying, you know, the big things we've had to be is flexible, is calm. In one of them, I thought, oh yes, calm's a good one in terms of, you know, ingenious and just, yeah, we've had to up our game really and have very different skills. And video consults require different skills than face-to-face consults. So I think we've all been on massive catch up to try and bridge that gap between how frustrated we are of not being able to do things in our normal way. But balancing that with the positives of, oh, this is great, you know, it is more involving for parents because they have to do it all. It is more engaging because we've had some consults where we've had perhaps fathers and mothers in different towns when they've been part of a video consult that we think, well, we'd never have had all those people in the room before. So I think it's tempering the frustrations of what you can't do with the success of the bits that you gain from doing the telehealth. And it's been interesting of the presentations I've sat in, just picking up that those are the skills people have really valued, and that flexibility and agility to do something different and do it quickly.
I find this, thank you, Jenny, because I agree so much with what you said. I find doing telehealth is time consuming, more time consuming than face-to-face. But I found another tool. For me, this is really a great learning experience because what I do, and the parents know that, they agree, I record the sessions and then I can review the sessions. And I've learned so many things from my mistakes, the way I talk to the parents, the way, do I wait enough time for them to respond? And I've noticed that some parents, you know, might nod their head, but you can see in their face. And usually when I'm face to face or when I'm person to person, I focus on the child. I look at the child. But now I can see the parents' reaction on their face, their vision, their eyes. Are they looking at what I'm doing? And there's so much that you can learn. You can, as if you're outside watching what's happening inside. And I'm a Bobath therapist. I'm used to working hands-on. How to describe to parents how much pressure, how do you hold the hand, how do you hold the child? So it really is, it has helped me be more precise in my communication with the parents or the child. Thank you.
Does anybody recognize that?
Yes, I want to fully agree with Vardit. I find my personal growth and learning is just, you know, it's really great because you have to learn to verbalize what you normally would have done without even thinking about it if you were physically present. And this is great because we try to convey to parents what they can do at home. And they look at us in clinics doing it, you know, in our therapy sessions, and they probably think, it's fine for you to do it. And I've often had parents say that, but this won't work at home. And now, you know, they find out at home, oh, I can do this. I can do this in the child's bedroom. Oh, I can do it at the sofa. We can use this chair. We can, you know, I can do this. And I think while it's very daunting for parents that they have to do all of this, that therapists usually do, they also are empowered and they find in themselves skills that they didn't know they had.
Great. Sarah, you wanted to comment as well, I think. You're still muted. You have to turn your microphone on, Sarah, otherwise we won't be able to hear you. You're still muted. Yeah.
I'll hold it now. I have to hold my mouse.
Okay.
Anyway, Joris, you were saying that your group could not come to an agreement about urgency. What does urgent mean? Well, what happens if a parent feels it's really, really urgent? Did they have like a venue to call you? It was their feeling that they have something urgent.
Yeah, they could always call us, and it was up to the doctor to decide who to see and who not. And in the first period, basically the only patients we were really seeing were patients with wounds from certain aids, like for instance an orthosis that didn't fit right. And if patients had a really big problems with swallowing and a really high risk of getting a pneumonia, those kind of patients we would see. And of course, as a doctor, you always take parents' concerns seriously. So if a parent calls you and say, this is urgent, yeah, you would often see someone. But I found that very little parents did report something like that. Where I think there was more urgency than parents reported.
Do you feel they were afraid to report it, Jorgis, because of the possible infection and so on?
Yeah, and a lot of parents didn't dare coming near the hospital, so they'd rather stay away, even if that wasn't the best for their child, and even if we would to the all best possibilities could say it was safe, but still they rather not take their child to the hospital, and they kept it away for months. I think that was a big barrier as well.
But you did see for example, you gave Botox, post-Botox and post-operative. You felt that they were urgent. Well, parents that are stuck, at home with their child and are the only ones that are caretaking their child constantly see all of a sudden things that they have not seen before. And they feel that that's really urgent. Well, would you consider asking them to video it and send it in to you rather than saying, well, the doctor makes the decision?
Yeah, of course, if that's possible, but not everything can be videoed, I think.
Cameras, cellular cameras.
Yeah, if it's possible, then that would be super. I got multiple videos of patients, of parents from patients asking me certain things. That's super, because that gives you something really to determine your decision on whether to see a patient or not. But I feel that less urgency was reported by parents than it should, than the other way around.
Does this go for domestic violence as well? Because we hear quite a lot of stories that during the lockdown, domestic violence took a rise.
I'm not sure, but I think it could very well be possible, yeah.
Any experiences on that from anyone? None.
Just that it's on the rise everywhere.
It would come out more. It would come out more in the open. Is that what you mean, Sarah?
Yes. And being a multicultural country, in a way, Netherlands also has many people that don't speak Dutch. We've had help from psychotherapists in that domain, with the translator often.
Yeah. I think that's very good.
Sorry, I think it's not just that it was more out in the open, it was the fact that because people couldn't actually get away from the abuser, so they were they couldn't escape from it, and so it just happened more, it escalated considerably.
I agree.
That's something to worry about then for a second or a third wave, I would imagine. People, we have to slowly close this session. It's 2 minutes to 1. Does anybody have a last remark?
Thank you very much for your
Thank you.
presentation. It was great.
Well, thank you for your participation.
Yeah.
Do you feel this is something we should do more often? Dawn says yes, or at least she puts her thumb up.
Well, maybe it would be nice to share the best practices with each other.
Yeah.
Probably we should all come to an agreement what urgent is. In all
Yeah.
domains, emotional as well.
Yeah. There was one kind of general statement. There was something like all care that, if not provided in the coming 6 weeks, results in severe or reduction in functioning, or something like that, translated in English. But that's very difficult. Like the emotional aspect, is that within 6 weeks? Is it severe? It leaves a lot of room for interpretation.
Something we will take along as a take-home message. Well, I would like to thank you very much, all of you, for your very interesting presentations. Jorgis, thank you very much for your presentation and for your contributions, all of you. I wish you a very happy day, and we will meet again.
Thank you very much.
Hopefully, yeah.
Bye.
Bye-bye.